on va passer à la communication de Monsieur Sherman Silber. Et là, je vous demande de vous lever et de le saluer vivement. We are very, very grateful for what you are done to travel from USA to come to Marrakesh, to take the plane and to bring with you the knowledge. Because pour les gens qui connaissent pas Sherman Silber, c'est un pionnier de la médecine de la reproduction et je le présente comme ça, c'est un géant, c'est un prix, il est nobilisable ce monsieur. Je vous rappelle que ce monsieur a fait toutes les spécialités, la microchirurgie, enfin la transplantation du rein, le cœur, de cardiac surgery also, and he is the first who did the vasectomy ligation reversal, the first also tubal ligation reversal, the first transplantation of the testicle in the 70s, the first transplantation of the ovary in 97, and now you are working with Japanese to make possible in the future, in 10 or 5 years, the possibility to have oocyte or spermatozoa from skins, and it will be very great if you arrive at this the end of this project. Thank you, and you will talk about this very interesting topic, in vitro maturation of oocyte and in vitro oogenesis. Thank you, Mr. Chairman. The floor is yours.
Y'all need the right side.
I think that there's never been any doubt in my mind that I wouldn't be cured of this. Once I found out, I just made up my mind, that's it. You just have to keep taking it one day at a time and just keep that positive attitude and know that I can do this. I'll get through it.
It's 8 o'clock in the morning, July 17th, 1997. We're at St. Luke's Hospital. And we're about to do the first case in the St. Louis area of ovarian tissue freezing. Okay, well, I'm Dr. Silber, Sherman Silber, the Infertility Center of St. Louis, and we really have a treat right now. This is Jennifer, who at 24 years of age, I'm right on that,
Yes.
right? Came down with a terrible case of leukemia. They thought she was going to die, but just to be safe, in case she lived, when she did, and was cured, we would freeze her ovarian tissue. So that was like 20 years ago. And this is the first case that we ever did, and we're the only ones right now really actively with a program in the whole United States. And it's been a long time, and we didn't know that we'd be able to transplant the tissue back, and we didn't know if we could culture the tissue. And here she is now. We had her on Facebook Live several months ago, and she was happily pregnant, and now look what we have. Now she's 44 years old, if I can reveal that, with a 24-year-old ovary, and a beautiful baby. What's her name again?
Madeline Grace.
Madeline Grace. Okay, so I just we begin with that interesting video because we didn't know in 1997 if what we were doing would have any clinical benefit. But you have to try an idea and then you'll see if it works. You can't be afraid. We told her there was nothing else we could do. We told her probably this wouldn't be of any benefit because we didn't want to transplant leukemia cells back in the future, and because we certainly couldn't mature the eggs directly from ovarian tissue to do IVF. Well, now we can mature the eggs from the ovarian tissue to do IVF, and that's basically what I'm going to talk about. First, let me briefly just give you an overture of how our ovary transplantation work beginning in 1997 led to this new approach. So we'll skip that. This is a patient who told us that she was very lucky she had cancer.
Children really scared and frightened me. 2 years ago, at the age of 21, Melissa was diagnosed with Hodgkin's lymphoma. She was told her treatment would include very high doses of chemotherapy.
I thought, I'm young, I can do it. The odds are looking really great for me. Hodgkin's lymphoma, very curable. And then I really started looking into my papers and my books that you get, and I came across fertility, and I burst into tears. I don't have a biological clock anymore. They took it away from me. So when I'm ready to have kids, it's not going to be a problem.
Well, Melissa, this is a fantastic moment for all of us. When are you going to have the baby?
We are scheduled for a week from yesterday, so six more days.
6 more days, and you look really ripe.
I am very ripe, yes.
So we've already frozen cancer patients, 127 pieces of ovary tissue, and they can come back 5 or 10 years later or 20 years later. And for example, that first patient had a 24-year ovary when she was 44 years old and got pregnant easily. And the second patient I showed you actually felt very grateful that she had cancer, because otherwise she would have been in her 40s and not able to have children. But she never worried about that because she knew she had a 20-year-old ovary in the freezer. And all the pregnancies are natural. No IVF is required. In fact, that's crucial for a high pregnancy rate. This is the way we quilt the thawed ovary tissue back together so we can place it back right where the destroyed ovary is, so that the fallopian tube can pick up the egg. If you try to do IVF in these cases, egg retrieval is very difficult, and you may only get 1 or 2 eggs at most. So it's best just to have the fallopian tube in the position where it can pick up the egg easily at the time of ovulation from the transplanted ovary tissue. And so all of our pregnancies have been natural. And that's the only way to have a high pregnancy rate. So we already have 32 healthy babies from this. We have 80% success rate, that's baby rate, with fresh ovary transplants. And with frozen ovary transplants, it's a 78% baby rate. Now, it's virtually 100% that the ovary tissue works and make hormones and ovulates. But not everyone gets pregnant. But we can plan on a 78 or 80% pregnancy rate, natural pregnancy rate with delivery of live baby with this approach. And this is just a very busy slide that sort of summarizes some of our results and shows that each piece of ovary tissue you transplant can last 8 to 12 years. And then when it runs out of eggs, you can just transplant another tissue. So in a way, these women never have to go through menopause. They have enough frozen ovary tissue that they can be making natural hormones till they're 100 years old. So, but now there's a much wider world population problem. The world is depopulating, as we know, and we need bigger solutions. And that will involve allotransplants and in vitro maturation. So this is the first successful transplant from a sister who is not identical to her Turner's sister. Her sister had Turner's syndrome, was healthy in every other way. She was simply short stature, very intelligent, and had no eggs and no hormone production. To transplant an ovary from her sister meant that we needed immunosuppression. And now we have safe immunosuppression protocols that allow us to do this without any fear that we're endangering the recipient. And this is just the typical graph, which will explain in vitro maturation. You'll understand that by the end of this talk. At first, we wait after about 4 months, the FSH begins to come down after a transplant. At the same time, the AMH goes way, way up, and then the AMH comes down again. And what we postulated, and what turns out to be true, is that because of a decrease in pressure when you do the transplant, there is an over-recruitment of primordial follicles, a massive depletion of primordial follicles. And because of that over-recruitment, 4 months later, the AMH goes very high. But then because of the depletion, the AMH after 4 or 5 months more goes down to low levels. But it stays at those levels, and the woman continues to ovulate for 8 to 12 years after that, despite very low AMH. And I'll explain in a minute that as the ovarian reserve goes down, the rate of primordial follicle recruitment goes down. So women with extremely low AMH can still have a long period of successful menstruation and ovulation. So this is the first baby born from ovary allotransplant. Now this means, now we know, it doesn't matter if they have a good HLA match or a good ABO compatibility, and they don't even have to be related. So that any ovary tissue from any woman can be transplanted to any other woman safely now, and that might avoid the ethical dilemmas created by the idea of donor eggs, because they can get pregnant naturally with intercourse without having to go through IVF or donor eggs. There's the first healthy baby growing up. And so now that was just a brief introduction to how we got to where we are now, which is in vitro oogenesis and in vitro maturation from ovarian tissue. So we started out with a collaboration with Japanese making skin cells in the mice, taking skin cells in the mice, turning them into stem cells and turning those stem cells into oocytes. So we worked closely with Dr. Katsuhiko Hayashi, who was able to develop this technique in mice, and now we're doing it in humans. There we are together. Usually you think of the Japanese as being short and the Americans as being tall, but we are reverse of that situation. I'm the short one. I'm the Y chromosome and he's the X chromosome. And there is a collaborator, Ori, who did a lot of the technical work with Katsuhiko. And then for translating this to humans, we work with Amanda Clark, and it's a combination of people that were supported by private equity, really. And we have no financial interest in this, but private equity is supporting us in this research. And one thing, you never know when you're going to find something fascinating that you didn't think you'd find just from doing something different. So my question comes is, when does sperm germ cell specification occur? When in the early embryo do these somatic cells, which are going to grow up and we're eventually all going to die, but when do these somatic cells become germ cells? Because germ cells are immortal. The germs, they never die. They just go on and on with repeated generations. It's philosophically mind-boggling to think about this. And the question is, with his identical twins, who one twin was depleted of eggs and the other twin had normal eggs and normal ovulation, was this genetic or epigenetic, or was it a misallocation of germ cells? Well, what we found out is it's a misallocation of germ cells in the early embryo. And because genetically and epigenetically they were identical, but one twin had ovarian failure in her teen years and the other twin was completely normal. So that means right after germ cell specification is when there was a splitting. And most of these patients we saw in the early days that were monozygotic twins, discordant for ovarian failure, almost all of them were monochorionic, monoamniotic, which means late splitting. So late splitting is between 9 and 12 days. If it splits after 12 days, it's Siamese twins. So we were able to conclude that germ cell specification occurs between 9 and 10 days in the early epiblast. And I'll show you what that means here. This is a diagram. This is a picture of a very early embryo. And that little green area, which is, of course, from green phosphorescent protein, that green area is an area in the early epiblast where what would otherwise become somatic cells are specified that they can only become germ cells. Early epiblast cells are separated from the rest of the developing embryo. They have to be, because the embryo differentiates and we become all the tissues of our body. but the germ cell has to remain separated from that whole process of differentiation. So in vitro gametogenesis, making sperm or eggs from stem cells, is just copying this early embryonic process. So oocytes generated in vitro from iPS cells will be very young because we're just recreating embryology. So think about this. In the future, once we have this perfected in the humans, and we're halfway there so far making primordial germ cells, in the future, a 38-year-old woman might be better off having a skin biopsy than an oocyte retrieval for IVF, because the eggs that we make, so to speak, artificially will be really very, very, very young fetal eggs, actually. And so once germ cell specification has occurred between 3 and 6 weeks of fetal life in the human, these cells which are kept outside of the body at the yolk sac then migrate. It's safe for them to migrate into the body and settle at the gonadal ridge. It wouldn't be safe for them to be in the gonadal ridge any earlier than that, because all that early differentiation is occurring, and we don't want the germ cells to be part of that early differentiation. So this is a simple outline of how we make an oocyte in vitro. And I know it's a word slide, but I'll read it because the last 3 lines are crucial for in vitro maturation of oocytes from ovarian tissue or from small follicles, which we can do today very highly successfully with babies. So primordial follicles are locked and by FOX3 and ovarian cortex tissue pressure. So ovary tissue really isn't very good for culturing to oocyte because the primordial follicles are locked. Now, what we do is we take skin cells and we convert them into stem cells. In a mouse, it takes 3 to 4 weeks of exposure to 4 genes. And then those stem cells are exposed to 3 other genes and make early epiblast cells in about 2 days in the mice. The epiblast cells, or like cells, are turned into PGC or PGC-like cells with exposure to other genes for 6 days. And I'll show that in detail, but go quickly because there's time limitation. Oh, I didn't mention, by the way, that anybody who wants these slides can just write to us and we'll send you these slides. So I want you just to understand the concept as I go quickly, because the details in the slides I can send to anyone who is interested. So then what we have to do is take those PGC cells, which are the beginning of oocytes, and incubate them with fetal granulosa cells for 3 weeks. And that we call IVD. It's important to know what IVD is. But we need fetal granulosa cells. Adult granulosa cells will not do the job. And then simply FSH culture for 10 or 11 days is the IVG phase, gonadotropin. And then just 1 day of HCG culture, and you need to add FSH2, and that's IVM phase, and that's how you mature. Now, I'm going to tell you ahead of time what I'm going to show you, that in the human, in the ovary, the IVD phase is about 4.5 months, and there's no gonadotropin sensitivity nor hormonal sensitivity. It is an inexorable process. There are many genes that are converting those recruited follicles into GV oocytes, and they are inert and hormonally completely. You don't even know what's going on until 4.5 months later when they become GVs that are sensitive to FSH and LH. Now, that period requires fetal granulosa cells. But then FSH culture in any animal you want to study ideally is a maximum of 11 days. And after that, then the oocyte is prepared for HCG and conversion by IVM. Now, I'll show you that in the human. This is the slide we made for humans, so you'll understand it. When the primordial follicles are recruited, it's about 4 months of IVD. That's in vitro differentiation. And this is gonadotropin insensitive. Now, then there's a period of 7 to 11 days of exposure to gonadotropin, FSH, and a low amount of LH that prepares the oocytes for maturation with HCG or LH. Now, this is what happens in vivo. So that means that on any given day in any woman's life, there are going to be 4 out of 12 GV oocytes that have been made meiotically competent, because less than 7 days of exposure to IVG and they cannot mature with HCG, and greater than 11 days of exposure and they will degenerate. So there is a constant sweet spot of about 35% of GVs on any given day in any woman's ovary that can mature very simply with exposure to HCG, and it doesn't matter what the dose of HCG is, what the concentration is, it's just a simple process that you can begin doing tomorrow in your IVF lab. It requires no special media. So I'll go quickly through this. iPS cells can be, and that means induced pluripotential cells, which is really stem cells that are made from somatic cells, can be readily made with just 4 known genes, which all can be purchased commercially. And you can see there, and one can use 3 genes, but the 4 genes give us a better quality stem cell. And I don't have to repeat that because you'll be able to get the slide. So 4 genes alone, exposure will turn somatic cells into stem cells. And once you've made these stem cells, then exposure to 3 genes, and it's listed there without any feeder layer, you can incubate those cells and they make epiblasts-like cells. And the epiblast is where the germ cells originally are specified. So 3 genes are required to make these epiblast cells. So then those cells are incubated with 5 genes, and behold, you have in vitro, you've made it primordial germ cells. And those genes are also commercially available, and you'll see what they are when you get my slides. So this is just an early diagram, which I don't want you to have to look at all of it, but just look, you can see on the top part, there is the stage of IVD, in vitro differentiation, depending on fetal granulosa cells. And after that, in the mouse, it's 21 days, 11 to 14 days of exposure to gonadotropin in vitro, and then 1 day of HCG. And any concentration of HCG will do, and you get a mature functional M2. And this is just another diagram comparing in vivo maturation to epiblast and to PGCs versus in vitro. And to understand in vitro maturation, or IVM, you have to differentiate between those 3 stages of oocyte development: IVD, which is in vitro differentiation, IVG, which is in vitro gonadotropin sensitivity, and then IVM, which is LH or HCG sensitivity. And the reason in vivo that a female baby's eggs aren't all gone when she's born is that they enter the ovary cortex, which is very tight, tough, fibrous tissue. And that tough tissue puts it in early meiotic arrest. So the woman has all the eggs she's ever going to have, and she doesn't lose them all at once because the tough pressure of the cortex in that fetus is preventing them all from developing. And there's a gradual stage of release over the course of the woman's lifetime based on the pressure gradient from high pressure in the outer cortex to low pressure in the inner cortex. And so during the first 3 weeks of culture, this is in the mouse, in the fetal granulosa cells, and 4.5 months in the human, this is IVD. So there's no sensitivity to any hormones. You don't need any hormones. And then you open up the follicles. I'll show you this on the mouse at 11 days and incubate with FSH for 11 days. And probably we should have been using LH along with FSH to get a greater efficiency. And so this is in the mouse, that conglomeration of fetal granulosa cells along with artificially produced primordial germ cells. And then after 11 days, we have to just dissociate them. We have to take them out of that normal pressure and open them up. And you can see what they look like. They look like GV oocytes with cumulus mass around them. And then these are the first two baby mice born from skin fibroblasts derived. The mouse's mother had been ovariectomized, and this came from the tail cells, that is the fibroblasts of the tail of their mother turned into oocytes. So what if we don't have fetal granulosa cells to convert skin-derived stem cells to primordial germ cells like in the human? Because we already have made primordial germ cells rather easily in women over 50 years of age who are in menopause, and we've made very good quality primordial germ cells, and that's been published. And I can send you those papers, but that's been published that we make primordial germ cells really well. But how in the world are we going to turn those primordial germ cells into competent oocytes? We need fetal granulosa cells. And in the human, how are we going to get fetal granulosa cells? So there are two possible solutions. One is to duplicate what fetal granulosa cells secrete to transform PGCs into oocytes, or transform these stem cells into fetal granulosa cells, and then we can incubate the PGCs with the fetal granulosa cells. So that's been done now in the mouse. Yoshino et al. Published this in 2021. What you do is you have separate cultures. In one culture, you're making primordial germ cells. In the other culture, you're making fetal granulosa cells. You mix the two together, and you have normal oocytes, and you never had to obtain fetal granulosa cells from fetal mice, and we won't have to do it from fetal humans. We'll be able to just make fetal granulosa cells. And because it's very complex, that process of fetal granulosa cells maturing an egg in IVD, and we don't know how to recreate that process other than to make fetal granulosa cells. So there you can see I'm the shortest one in this group of tall Japanese, and that was our original work. But now I know you want to know about in vitro maturation, and I think it'll be easier to understand. It's going to be shocking to you how easy in vitro maturation will be, where you don't need any special media or any special concentration. It's all based on in vitro oogenesis. Again, I'll remind you with this slide that in the human, we have 4 months after follicle recruitment of IVD, which is hormone insensitive, and there are so many gene transcripts that are converting that primordial germ cell into an egg that's capable of being sensitive to gonadotropin. So in vivo, this is all happening. 4.5 months after recruitment, they've completed IVD, and they're just ready for, and they've even completed IVG, and they're ready for IVM. It's a constantly changing dynamic process. So on any given day in any woman's life, 4 out of 11 GVs have been exposed to more than 7 days and less than 12 days in vivo of pituitary gonadotropin. Now, this is the most important slide of all. If there's less than 7 days of exposure to gonadotropin, those GVs will not mature. If there's more than 11 days of exposure to gonadotropin, the GVs will lose competence and will degenerate. So understanding how this works allows for very easy IVM of GVs and also more effective stimulation protocols for PCOS on one hand and low ovarian reserve on the other. So we do not need ovarian stimulation for oocyte maturity. In vivo FSH has already created GVs with meiotic competence. We do not even need normal ovulatory cycle for meiotic competence of GVs. We only need ovarian stimulation, or without stimulation, the ovulator or hormonal cycle. There's only one reason we need that. That's for follicle enlargement, and so that we can retrieve the oocyte. You're stimulating a woman with hormones is not to get better quality eggs. It won't do that. In vivo, that's happening anyway. The only reason for stimulation is to make follicles so that you can easily retrieve the eggs. So that's, again, a reminder that the primordial follicles are locked in the ovarian tissue cortex, and so that pressure prevents them from all being recruited at one time. And recruitment is controlled by the pressure differential. I'll show you that. Let me show you that. Okay, so here we have a piece of ovarian tissue from an ovary allotransplant we're about to perform. And we're going to show you how we dissect, and we've got 65 cases already like this from ovarian tissue. And after we've done the dissection so that we have the cortex ready for freezing, we search the spent media. So we've dissected out the cortex from the medulla, and we just now search the media. We don't throw it away. And this is a histology slide that shows you what I mean. When we dissect away the cortex preparing for ovary transplantation, there will be GV oocytes developing follicles that are internal, because the development always occurs from outside to inside, from high pressure to low pressure. And there's a perfectly normal GV oocyte that we're going to be retrieving in the spent media after the dissection of the cortex. And they look like this. You can see they're oocytes that are GVs surrounded by a tight cumulus complex. And after 1 day of incubation in HCG, you can see already we have 3 out of 5 in that group, metaphase 2 oocytes. We have one that's degenerated and one that's just still a GV. So again, remember that the oocytes that will develop into M2s have had greater than 7 days exposure to gonadotropin, but less than 12 days exposure. If they've had more than 12 days of exposure to gonadotropin, they will degenerate, like that top follicle. If they've had less than 7 days, they just won't mature at all, like the follicle on the upper right. And here again, you can see this is on day 1. This oocyte has not matured, but then we have beautiful maturation of oocytes again here on day 2. And so we have predictable IVM results with any medium and any concentration. We did a variety, I'll show you the table, on any given day in every woman's ovary. 4 out of 11 GVs have been exposed to more than 7 days and less than 12 days in vivo pituitary gonadotropin. Less than 7 days and they will not mature. More than 11 days and the GVs will lose competence. Thus, 30 to 40% of GV oocytes on any given day in any woman's ovary should be able to become M2 oocytes with any medium and any concentration of HCG or LH. So our results of 166 oocytes were that 32% became M2s, but it varied between 18% and 56%. And the only case of low maturation rate, 9%, occurred when the cumulus was stripped immediately. We wondered how important the cumulus was at this stage, and we found out it's still very important. The cumulus is still critical for 24 hours of exposure to HCG. This is a slide that's very busy, but when you get my slides, you'll be able to read through all of them and see that some of them were exposed to 1,000 MIU of HCG per ml, and others were exposed to only 10 or 20 milliunits of HCG. And we had good maturation with all of them. And we used a variety of different media, and IVM media wasn't necessary. Your ordinary IVF media is good enough. Now, there is a problem, though. Repeat again. IVM doesn't require any special media or any specific concentration of gonadotropin. Very, very low or very high concentrations work very well. The next point I'll make is that as the ovarian reserve goes down, the rate of primordial follicle recruitment goes down. I'll talk about that more this afternoon. But here's a 38-year-old woman who is still fertile despite a low primordial follicle recruitment. She actually has good eggs. She is donating her ovary to her daughter who has Turner syndrome. And these few oocytes will eventually be ovulated. But for this particular case, she had perfect in vitro maturation despite having such a low ovarian reserve. 1/3 of her oocytes in vitro developed into good M2s, and she'll have those available for her daughter also. So in older women with low ovarian reserve, the fibrous tissue, the ovarian cortex, is thicker and denser, so follicle recruitment is slower. And I'm just showing you that visually here. And yet we can get good maturation of the oocytes that we attain from that ovarian tissue if we just look at the spent media. So what if the patient, however, already had chemotherapy? Or what if she is on birth control pills, or if she's prepubertal? Well, then we don't get IVM. There has to have been prior exposure to gonadotropin, or we won't get IVM from the ovarian tissue. They need more than 7 days and less than 11 days, or less than 12 days of exposure to gonadotropin in order to have IVM occur. What if the patient was on progesterone-only birth control pills? Well, that seems to be no problem. If they're on combined birth control pills, that is enough suppression of gonadotropin. But if they're just on progesterone-only birth control pills, we got very good maturation. You can see good M2s developing from those patients with cancer that before retrieving the ovary that were on progesterone-only birth control pills. So why does it not require special IVM media? Why does IVM work? Well, it's so easy because GV oocytes dissected from ovary tissue have already become meiotically competent in vivo by what we term IVD and IVG. It is far easier to obtain many GV oocytes from tiny follicles using open cortical dissection than using a needle. Now, you can do it with a needle. It's just very difficult, and it's limited to PCOS patients with a huge number of small follicles. It doesn't work if you strip the cumulus before 24 hours, and it does not work for prepubertal ovaries that have had no IVG exposure, or if initial chemotherapy has been given, so there's no GVs. But in cases where IVM does not work, ovary cortex transplant will still work because primordial follicles are very robust and remain viable. So we do not need ovary stimulation for ovary maturity. This will be very important when I talk later about minimal stimulation protocols for IVF. We really do not need high doses. In fact, high doses of FSH are very harmful. FSH has already created GVs with meiotic competence, and we do not even need normal ovulatory cycle for meiotic competence of GVs. We only need it, or ovary stimulation, for making follicles for easy retrieval of eggs. But you can still retrieve eggs. It's very difficult with a tiny 22-gauge needle that are not developed into pre-ovulatory follicles, and they've had all the exposure to gonadotropin already in vivo that they need to be matured. So this is just a picture of our team in St. Louis. I showed you the picture of the team in Japan. This is our team in St. Louis, Missouri, and we have a strong collaboration on this project. So I thank you very much. I went through a lot, but I'll be glad to answer questions.
Thank you, Mr. Sherman, for your outstanding topic. Est-ce qu'il y a une question dans la salle? Yes?
My hearing is bad, so speak slowly and clearly if it's bad hearing.
I will help you.
Okay.
Yes. Thanks for your excellent presentation topics. I have two questions. The first, because we start in our country, the first cryopreservation or ovarian cortex last year. I start with the slow freezing technique, and I saw in your presentation that you use also vitrification. I want to know your experience with vitrification. Is there some births after this technique?
Vitrification and
slow freeze?
Yes, slow freeze.
Oh, okay. So if I understand correctly, you're asking about the difference between vitrification and slow freeze. Well, I think we all know by now that for freezing oocytes or embryos, vitrification is far superior to slow freeze, and I don't think that's controversial. The question, though, is about ovary tissue. Well, we are using only vitrification now for ovary tissue, but that's only because it's easier. We compared slow freeze tissue transplanting back and vitrification tissue transplanting back, and we found there was no difference. So I think that slow freeze, which most of you are doing, is perfectly okay for ovary cortex tissue. Vitrification is just quicker and easier, and that's why we prefer it. But we could not argue that vitrification is any better. Now, there's a reason for that. and that is that the primordial follicles in the cortex are only 3 microns. They're not 150 or 180 microns, and they are only in early prophase. There really isn't much of a metaphase plate. So they're not so susceptible to ice crystal formation damage as a mature oocyte would be. And that's why with over tissue freeze, slow freeze is just as good as vitrification.
Thank you. I have a second question. Me too, when I found always VG and sometimes metaphase 1 with the cortex, I vitrified them. And do you vitrify it in stage GV or after in vitro maturation to metaphase 2?
I'm not embryologist, but he said but she said when you found. Tu peux rappeler en français parce que.
Oui, parce que quand je fais le cortex ovarien.
Non, je suis pas biologiste donc.
Oui, je vais te dire en français.
Exactement la question, c'est quoi?
En français ou la.
Exact.
Oui, c'est quand on prend le cortex et on trouve dans le milieu où on ponctionne des ovocytes, souvent c'est des VG, et je les congèle. Je pense qu'eux, ils les font d'abord maturer en méta 2 avant congélation. C'est ça la question.
We take the cortex and we take the oocyte. The VG, you do maturation before freezing or you freeze the VG?
Okay. So if I understand the question, you want to know when we do the freezing. So we're separating the cortex by dissection. And one person from the laboratory will then take the ovary cortex and vitrify it. At the same time, another person in the laboratory is looking at the spent media. And it may take an hour or so to look through the media for all those GVs or cumulus complexes. So we do it at the same time. While the ovary tissue is being frozen, we're also looking for the GVs. Then we put the cumulus complexes in culture with HCG, any concentration of HCG whatsoever. And we also know from our work with in vitro gametogenesis, you also need FSH, not only HCG, but HCG and FSH. And then we check them at 24 hours and 48 hours. Ideally, it would be 24 hours and 44 hours, but 48 hours makes it easier for the laboratory schedule. And we have some of the eggs have become M2s at 24 hours, and they've all become M2s by 48 hours. And then we vitrify them whenever they become M2s.
Okay, thank you.
Est-ce qu'il y a d'autres questions dans la salle? Samir, sinon j'en ai une également.
Thank you, Chairman, for this excellent lecture. So, what is, you mentioned clearly about the competence of fetal granulosa cells as a sweet spot. What is the secret? Do you mean that these fetal granulosa cells express clearly transcription factor that you mentioned in your talk?
You talk about the competence of granulosa cells, fetal granulosa cells. You think that the competency.
You
can repeat the last part of your question?
No.
La compétence.
So I repeat my question. So you mentioned clearly the secret and the fetal granulosa cells as a sweet spot. Do you mean these fetal granulosa cells express clearly all transcription factors, and this explains why you can derive it in primordial follicle and then oocytes?
The question is about the granulosa fetal cell and the transcription of these cells. What do you think about it?
Bon, ben laisse tomber. Anyway. Est-ce que ces follicules, les facteurs de transcription qui leur permettent d'aller jusqu'à l'obtention de ovocytes?
C'est compliqué pour moi. Je suis
Ask him in French.
Huh?
Ask him in
No,
French.
it's not a problem of language. It's a
Chairman,
problem.
you hear me?
Yeah, okay.
You hear me now?
Yes.
Great. You mentioned clearly about the competence of fetal granulosa cell.
Yes.
And you consider as a sweet spot.
Yes.
What is the secret of this fetal granulosa cell? Do you mean these cells express clearly all transcription factors which permit to reach oocyte GV stage?
Yeah, let me explain that again. Okay. I need to explain, I think, again, the issue of why we need fetal granulosa cells and not adult granulosa cells, and also what is this sweet spot. Well, we know from doing the artificial oogenesis or gametogenesis in different animals that for any animal you want to study, if they have less exposure, less than 7 days of exposure to in vitro to gonadotropin, they won't mature. They have to have between 7 and 11 days of exposure, and actually 11 days is ideal. But as soon as you go over 11 days of exposure to FSH, then those oocytes degenerate. So there, in any woman's ovary at any day of her life, there will be about 35% of the GVs that have finished the IVD phase and become GVs. 35% of them will have had an adequate but not too much exposure to gonadotropin. And therefore, they will simply mature very easily with HCG. What's happening with fetal granulosa cells is very complicated. But we know that adult granulosa cells do not make the transcripts that are necessary to convert a primordial germ cell into a competent GV. So that's a black box. And in the mouse, that's 3 weeks of a black box. In the human, it's 4 to 5 months of a black box. So when you're retrieving eggs from your patient after ovarian stimulation, those eggs that responded were initially recruited from their primordial follicles 4.5 months earlier. And you don't know anything about them until they actually become sensitive to gonadotropin and enter what we like to call the IVG phase. So is that clear? Okay.
Hassan, une question.
I'm sorry for my bad hearing.
I'll try to take something. Mais les autres doivent comprendre.
Vas-y.
So from this wonderful work, I want to have something to do in my daily practice. In many cases, we stimulate for 8 days and we reach the criteria for triggering, 17, 18 millimeters. Would you recommend to go over this 18 millimeters for 10 days at least, or 11 days of stimulation, even if we reach criteria of triggering to have better maturation in daily practice?
You have to tell me what he
The
said.
question is about when we stimulate patient and we didn't reach 17 and 18 millimeters. Can we go more than to reach this criteria for triggering our patients?
Okay, so the question is, what have we learned about ovarian stimulation from this in vitro maturation work and the in vitro gametogenesis work? I think we're all familiar that follicles that are 1.7 or 1.8 in diameter are most likely the best follicles for triggering. As soon as you get into bigger follicles, there's the risk that they've had too much exposure to FSH already, and you'll either get no eggs or you get poor quality eggs. However, we know that if the follicles are 1.4 or 1.5 in diameter, that you'll get many GVs that do not mature in vitro and poor quality eggs. So that's just an expression of the fact that you need a certain minimal exposure of more than 7 days to gonadotropin, but you don't want too much exposure, more than 11 or 12 days exposure to gonadotropin before you're triggering with HCG. That's true in all animals. It's very, very universal. That's what's so fascinating about it. We found it to be true in any animal you want to examine with in vitro.
Mr. Chairman, thank you very much.
Thank you for your attention.